Good afternoon, everyone. Welcome to our second primary care office webinar and peer discussion. This is focused on patient-centered medical homes in rural and underserved areas, and we're so glad that you can join us. My name is Megan Miller. I'm the Senior Director of Health Integration at the Association of State and Territorial Health Officials. And again, I want to welcome you to our webinar today on patient-centered medical homes in rural and underserved areas. ASTO is committed to supporting state and territorial health officials and their leadership teams within the transforming health system. And just, I'll go through some housekeeping items, but just a note for everyone to please mute your phone lines so we can reduce background noises. And also please note, don't put your phone on hold if at all possible. We'll hear music and sometimes that's challenging to stop. So just a reminder to please don't put us on hold and try to put us on mute, please. So ASTO, with support from HRSA, is providing this webinar to facilitate the sharing of best practices, address emerging issues such as payment and delivery reform, and foster collaboration and partnership among PCOs. Each webinar is 1 hour, and we'll have time set aside for discussion with participants and to answer any of your questions. In an effort to reduce background noise, I ask again that you mute your individual phone or handset during the presentations and when you're not speaking. If you have a question during the call, you're welcome to post it in the chat box on your screen at any time. These questions will be answered during the Q&A at the end of today's presentation. We'll also open the phone lines again during the Q&A session, and you can unmute yourself and ask additional questions for the last 15 minutes of the call. At the conclusion of this call, you'll be directed to an evaluation survey, and please take a few minutes to complete this survey, as we'd appreciate any feedback you have to help inform ASTO's future work with PCOs. Now I'm going to introduce today's speakers. First, we have Rachel Yalowich. Rachel Yalowich joined NASHP in August of 2012. Her work primarily focuses on Medicaid delivery system and payment reforms and issues related to chronic and vulnerable populations. Specifically, she works on advanced models of primary care, including patient-centered medical homes and health homes, community care teams and shared support resources, behavioral health integration, and payment and delivery reforms for federally qualified health centers and other safety net providers. Rachel's work includes policy research and analysis, evaluation, and technical assistance to states. Rachel graduated cum laude from St. Lawrence University with a Bachelor of Science degree in biochemistry and sociology. Our second speaker is Jenny Samuelson. Jenny Samuelson leads the Vermont Blueprint for Health Expansion and Quality Improvement Program, which consists of a team of 13 highly trained practice facilitators who assist over 100 adult, family, and pediatric primary care practices to implement continuous quality improvement. In addition, Ms. Samuelson oversees the statewide implementation of the Blueprint community-based self-management programs, including 6 evidence-based programs: the Stanford Chronic Disease, Chronic Pain, and Diabetes Self-Management Programs, the Vermont Tobacco Quit-in-Person Tobacco Program, Wellness Recovery Action Planning, and the YMCA's Diabetes Prevention Program. Before joining the Blueprint, Ms. Samuelson administered diverse community and statewide public health programs, including leading a 4-county health careers workforce development program, quality improvement with health systems to support tobacco cessation in primary care practices, and directing the state of Vermont's lead poisoning prevention program. I'll now turn it over to Rachel to start her presentation.
Good morning, everyone. Thanks so much for joining today. My name is Rachel Yalowich, and I work for the National Academy for State Health Policy. Let's see. There we go. So who is NASHP? We are a 28-year-old nonprofit, nonpartisan organization who's dedicated to working with states across branches and agencies of government to advance, accelerate, and implement workable policy solutions that attempt to address major health care issues. I'm pleased to join you all today to talk about patient-centered medical homes. Today my presentation will provide you with an overview of the patient-centered medical home model and conclude with a few slides on how patient-centered medical homes are the foundation of broader delivery system reforms at the state level. So what is a patient-centered medical home? This definition and diagram comes from the Agency for Healthcare Research and Quality, and they define a medical home based on 5 core tenets. One, that patient care should be comprehensive, meaning that it's more than just medical care. It should be patient-centered and high quality. It should also be accessible to patients, including enhanced access and after-hours care, and of and it should be coordinated to help patients navigate the complex healthcare system that we live in, and ensuring increased access to specialty care, hospital care, and community-based services, to name a few. The underpinnings of a patient-centered medical home that aren't necessarily represented in these core tenets include the patient-centered medical home really cannot function without a team-based model of care, including in the workforce, and also payment aligned with the goals of the program and qualification standards. And lastly, health information technology is a key underpinning of the model, as is in order for practices to do continuous quality improvement. Having the capacity to produce and use data is incredibly important. So NASHP has been tracking patient-centered medical home activity within state Medicaid programs since 2008, and to date, currently 24 states are actively making Medicaid payments to medical home practices in their states. 14 of those initiatives are multi-payer. NASHP has a delivery system and payment reform map on our website, and you can access that through the link at the bottom of the screen. We will hear later from Jenny about the Patient-Centered Medical Home Initiative in Vermont, but if you would like to learn more about a particular state, or perhaps you see your state colored in on the map, I would strongly encourage you to go to our website, look at the map, and once you get there, you can click on the colored in states, and it will tell you a lot more information about the program design, goals, payment model, and outcome measures and evaluation results where available. So qualification standards, what does it take to become a medical home? There are numerous types of qualification standards. Many of you know of the national standards. NCQA, Patient-Centered Medical Home Recognition, is certainly the most common that NASHP sees nationwide. There's also a lot of states and practices do have Joint Commission Medical Home Certification, URAC, PCMH Achievement, and AAAHC certification and accreditation. However, those aren't the only type. Those national standards aren't the only standards that are being used. Some states, such as Oregon and Minnesota, have developed their own state-specific qualification standards. So, for example, Oregon's 6 core attributes, they're very similar to the tenets you saw in the AHRQ definition, but they include access, accountability, comprehensiveness, continuity, coordination, and patient and family centeredness. So if you'd like to learn more about those state-specific qualification standards, more information is available on that state's page on NASHP's Delivery System and Payment Reform map. Lastly, we also see some hybrid qualification standards across the country. By hybrid, I mean states that are using national standards in conjunction with state-specific requirements. And a good example of that is the state of Maine. They require, in their Medicaid Patient-Centered Medical Home Program, they require practices to achieve NCQA recognition, but also achieve 10 core standards, which include behavioral health integration, cost containment efforts, continuous quality improvement, and a focus on population health management, just to name a few. Let's see, a little more on qualification standards. So meeting these qualification standards is often necessary for practices to receive enhanced reimbursement from Medicaid or other commercial payers and Medicare, depending on which program they're participating in. Standards are often a helpful guide and roadmap for practices, but with the caveat that just achieving medical home certification and achieving these qualification standards does not always equal practice transformation. It's really critical that practices have support and guidance and coaching, or to the extent possible, to really help them transform their practices and implement the core underpinnings like health information technology that are necessary for a medical home. And another caveat is that national standard programs, both initial and recurring certifications, are often an expensive burden on practices. So that's something that needs to be considered when states are developing a medical home program. So for folks that are interested in more information on patient-centered medical home accreditation and recognition programs, the Medical Group Management Association put out a crosswalk of different national standards in 2014, which I've linked to on these slides. And hopefully our friends at ASTO can share these slides with you all if they haven't already, and you can link to that resource if you're interested in learning more. And I know from folks at ASTO that many of you are interested in learning more about NCQA recognition. So NASHB is not of course, just as a caveat, NASHB is not a representative of any of these national measurement or qualification standard organizations, but we can provide we have pulled together some information based on their website and our knowledge of working with states who use NCQA. So the current standards, which are the 2014 standards, focus on 6 core tenets. Those include patient-centered access, team-based care, population health management, and care management, care coordination, and lastly, performance measurement. These 2014 standards are a bit of a departure from the 2011 standards, and standards that practices in your state may have initially been certified under. These standards have an increased focus on behavioral health integration, aligning with meaningful use implementation, and care coordination. And just also to note, the next redesign of NCQA recognition is coming in 2017. So more information on NCQA, it estimates that it takes a practice 3 to 12 months to develop workflows and document the practice's achievement of standards. So it's a lengthy process. Practices document this information in an electronic survey tool and submit an online application. And again, if you are interested in learning more about this recognition, if it would help you work with the FQHCs and other practices in your state, I encourage you to look at the NCQA website or reach out to me, and we can try and connect you with a couple of folks that we know there to get more information. So how are medical homes supported? Patient-centered medical homes are supported by payments from Medicaid that take a variety of forms. Sometimes they are reimbursed through enhanced fee-for-service for certain types of visit codes. Per member per month payments are certainly the most common type of supplemental payment to support medical homes that NASHB sees nationwide. Lump sum startup payments, those we don't see quite so often anymore, but a few years ago those were very common when an initiative was starting up to help practices defer some of the costs of transforming to become a medical home. Lastly, we also see that patient-centered medical home practices can earn performance incentives based on certain quality outcome measures. And like I said, the most common payment model that we see is a per member per month payment model, and often they are combined with a performance incentive payment to encourage quality improvement. And so, as I said in the very first slide, one of the core underpinnings of the patient-centered medical home model is team-based care. So that team often includes, of course, doctors, nurse practitioners, physician's assistants, nurses, medical assistants, and front office staff. The key with the patient-centered medical home model of care is someone on the team to promote care coordination. And really helping those patients navigate the healthcare system and access specialty care, hospital care, behavioral health, and dental services, and other community-based services as well. But NASHB is seeing that many patient-centered medical home practices are also employing a variety of other folks in their practices or sharing them on a team with other practices in the state. And those include nurse care managers, licensed clinical social workers, and other behavioral health providers, community health workers, pharmacists, and data analysis or health information technology staff. And Jenny will talk more about the multidisciplinary teams that they are using in Vermont, the community health teams, during her presentation, I'm sure. But it's very common, especially in rural areas. Sometimes practices don't have a large enough panel to support hiring these additional staff members. So many state initiatives have developed these multidisciplinary teams which employ many of these folks like nurse care managers and licensed clinical social workers, and then practices participating in the medical home program have share these staff across. So where do federally qualified health centers fit in? So federally qualified health centers are participating in the majority of Medicaid medical home initiatives. And federally qualified health centers have received a tremendous amount of financial support from HRSA over the past few years to support the development of medical homes. And I won't read all of those, but just some examples of the federal funds that have gone to health centers to make improvements to their buildings and facilities or expand the capacity and scope of services. One of HRSA's goals is to increase the number of health centers that have achieved medical home recognition. And currently, as of August 2016, over 65% of health centers nationwide have achieved this recognition. So we talked a lot about the medical home model itself, and I want to leave you with, at the end of this presentation, a broader picture of where the medical homes fit in broader Medicaid delivery system reform. So medical homes are really the strong foundation of which to build other delivery and payment reforms. As you go along the road helping to support medical homes, you see states implementing the multidisciplinary team models that I spoke of on the workforce slide, providing additional staff to help support medical homes and provide patients with access to care coordination and care management services. Moving further down the line is we see states developing accountable care organizations which group practices and hospitals into different entities, and they are at risk or responsible for providing care and containing costs while increasing quality. And then lastly, at the top of the road here, we show sort of the current pinnacle of delivery reform, and that's integrated healthcare systems. So continuing on the medical home, as I mentioned, the multidisciplinary teams many states have found crucial in the success of their medical home programs, continuing to engage behavioral health and dental health providers as part of the medical neighborhood and integrating those services into practices. And lastly, engaging patients and families and caregivers in their care and developing more patient activation and shared decision-making tools within their practices. So at the pinnacle of what the current pinnacle anyway of delivery system reforms is thinking about an integrated delivery system. So the key model features include high-performing primary care providers like medical home practices. These systems emphasize care coordination across providers in the healthcare system, shared risk, and population health management. So just to give you a sense of what's going on nationwide, delivery system reforms and payment reform initiatives are spreading rapidly nationwide. As you can see in this image, this is an image from the Center for Healthcare Strategies Accountable Care Organization activity map. Currently, they report 9 states have active Medicaid ACO programs, and in addition to that, and not pictured here, we see 35 states and the District of Columbia have received funding from the Center for Medicare and Medicaid Innovation, their state innovation model grants, testing and design grants to develop and implement various advanced delivery system and payment models. So medical homes, and you'll notice a lot of these states are the same states that are colored in on NASHB's medical homes map, because medical homes are such a key foundation to these broader reforms. And lastly, I thought I'd leave you with an example of Oregon and their coordinated care organizations which are an accountable care organization like entity, and they are really working to contain costs while increasing quality, and have used medical homes as a strong foundation in their work. These organizations were authorized by legislation, and these entities received a fixed global budget to provide physical, mental, as well as dental care for Medicaid enrollees, and they also assume risk and are intended to transition the way that providers are paid away from fee-for-service and toward more value-based payment models. And there are currently 16 CCOs operating in Oregon, and they, as I mentioned, they really do use CCOs contract with the medical homes, and they really do use those as a strong foundation for being able to accept risk and contain costs while increasing quality. So with that, thank you very much. I'm happy to take questions at the end of the presentation, and there's also my contact information in case you'd like to follow up on anything that I talked about in the presentation. And with that, I'll turn it over to Jenny.
Good afternoon, it's Jenny Samuelson. I am with the Vermont Blueprint for Health, and I think that my presentation will go well along with Rachel's to show you an actual concrete example of the implementation of the models that we've been discussing. I also am privileged to have my colleague Julianne Krowitz with us today, who could share a little bit more in detail of the work that we've done with FQHCs and practices on the ground. To get started, I'm going to tell you on our journey, I'm going to tell you a little bit about the components of the blueprint that we've built off and built from. So in Vermont, we are privileged in 2008, so some time ago, even before the Accountable Care Act, to have had a legislature and a governor and insurers who were able to come together and begin the process of piloting and designing the Blueprint for Health. By 2010, we had implemented a pilot that had included the introduction of patient-centered medical homes in our state, participating on a voluntary basis in the Blueprint for Health. In order to participate, each of those patient-centered medical homes became recognized by NCQA as a patient-centered medical home. They had participated in the process of designing and building community health teams, had implemented across their communities and across the statewide self-management programs, and more recently have evolved their integrated health services team meetings to community collaboratives, which I'll discuss in more detail. In order to facilitate this, I want to be respectful and tell you a little bit about some of the interventions that were necessary. Specifically, Vermont invested in staffing to help develop a community learning health system across communities in Vermont, which included practice facilitation staff, statewide quality improvement projects, and information and data collection. In addition to that, we have invested a significant amount of time, energy, and money in a health information technology infrastructure, which includes a health information exchange. It includes an all-payer claims database, and the merger of several different types of data together for us to be able to provide analytics and reporting back to both our practices and our communities. All of these are supported not just with Medicaid payments, but with multi-insurer payment reforms, we have agreement that in Vermont, in order to be an insurer, you must participate in the blueprint. Although it's willing on the provider and practices side, it is compelled by legislation on the insurer side. So that includes participation of Medicaid and our commercial insurers, and through a demonstration project also included participation in Medicare as the project went on. Let me tell you a little bit about the patient-centered medical home journey. And at this point, I'd like to emphasize that this includes a broad breadth of different types of practices. It includes hospital-owned practices, all of the FQHCs in Vermont, independent practices around the state. Many of them can be a part of groups, or they can be a part of individual communities. So for our practices who participate in the Blueprint for Health, we ask them to implement 3 things in order to get payment reforms. And there are 2 types of payment reforms. In our state, practices receive a per member per month payment, and the community on their behalf receives a community health team payment. Those payments are triggered by the practice agreeing to implement ongoing quality improvement, and in that process, becoming recognized as a patient-centered medical home through NCQA. Julie will talk a little bit more around some specifics around what NCQA recognition looks like in Vermont. In addition to that, each of the communities, and we have 4 distinct hospital service areas which are geographically dispersed and include a non-competing hospital in it. Each of those health service areas, as we call them, came together, including the hospital, the health and human services providers, and the primary care practices, to identify the gaps in services that they perceived, to identify how they could reorganize the current services they had to fill those gaps, and then using a payment provided them by all of the insurers in Vermont, they were able to hire additional staff to help support the patient-centered medical homes and the communities at large. So in our case, the patient-centered medical homes share services across the community. Typically, what that looks like is an embedded care coordinator and mental health provider, often directly into the practices, and then additional services like health coaching, nutrition counseling, pharmacology, and other services as designed by the local community, implemented at the community-wide level and shared between practices. In addition to that, to participate in the Blueprint, we asked practices to try to connect to our health information exchange and have put significant time, energy, and resources into supporting them in both the connectivity and reviewing the quality of the data that goes into the health information exchange. Through this process, we've identified some key needs and some key investments that were made in Vermont. As our communities began to implement the patient-centered medical homes, we were at the same time implementing community health teams. Very early on in our pilot, we recognized that community health teams, which are those shared members, were necessary to support practices in helping to become recognized as patient-centered medical homes. Performing within their practices both population health activities such as panel management and complex care coordination for high needs, high risk patients within their practices. In addition, we don't isolate our primary care practices, but consider them as part of a larger integrated health system. And the community health team's function is to help to promote cross-organizational, team-based care between the patient-centered medical homes, the hospital, and the community-based services, including working with the designated mental health agencies, the Visiting Nurses Association, the local housing organizations, the local law enforcement, and a myriad of other organizations to create both plans for the individual patients and for improvements across the general health of the community. In addition to that, in order to become recognized as a patient-centered medical home, we recognized very early on that it was helpful for the practices to have 2 different skill sets in their practice. The first skill set was someone who could work with the practice to implement the actual intent of the NCQA standards, which was ongoing quality improvement. this is really focused on trying to ensure all of the 6 standards that NCQA has implemented on an ongoing basis. So the practice facilitators that we employ not only assist the practice with NCQA recognition, but continue to work with the practices throughout the 3-year cycles. In addition to that, when we first started, we felt that it was really important for there to be a pool of individuals who were highly trained in NCQA. And for the first 5 years of our program, we had outside evaluators in addition to the facilitators who became proficient and gained expertise on the NCQA standards, could review documentation prior to it being sent to NCQA, were familiar with the systems for uploading that documentation, and did that on behalf of the practices. In more recent years, we found that we were able to merge those 2 different skill sets, and the facilitators fulfilled that evaluation requirement, assisting the practices in becoming experts in NCQA and uploading their documentation and materials. I also want to note that just like on where the community health teams were connecting with community-based organizations, as time has evolved, our practice facilitators have also assisted practices in connecting with community-wide quality improvements, both assisting the community writ large at helping to organize that quality improvement and helping practices to implement the needed strategies within their own organizations. So that way we're not just looking at within organization quality improvement, but quality improvement that crosses the boundaries of multiple organizations in a community. That we'll discuss as being our community collaboratives at the local level. The third investment that we made is we recognized that most of our practices and most of our communities lacked data and analytic skills, and even where they had it, they lacked the access to data so that they could do comparative reporting across organizational boundaries, so that we could compare one practice in one health service area to another practice in another health service area. So in this case, we made investments both in the health information technology infrastructure that I discussed previously, and we made sure to do reporting at the practice, organization, and community level. On an every 6-month basis, we provide health service area and practice-based profiles to each of the communities and to each of the practices at large. Those practice profiles, the practice profiles for the community and the health service area profiles and the practice profiles, help to drive our enhanced payment. By last year, we implemented a modifier where a portion of the per patient per month was based on the NCQA recognition, and a second portion was based on the performance of the practice and the performance of the community at large on certain ACO key quality measures. So the data not only is used as a feedback loop, but it also helps to trigger payment. Again, I want to reinforce that at all 3 of these levels, both our investments of our staffing at the community health team level, the quality improvement facilitators, and the data, that there was specific interest in ensuring that the work happened within the organization or within the individual practice, but also across the integrated health system, helping to begin to go towards, as Rachel showed in one of her last slides, that integrated health system at large. In the last few years, we've had accountable care organizations form in Vermont. We had three accountable ACOs which formed. One which served primarily hospital-owned practices with a mixture of some FQHCs and independents. Another which served the majority of our federally qualified health centers in the state, and a third which served independent practices. It became imperative for us to work very closely with the infrastructure that we'd already laid on the ground to help support the strength and investment in those ACOs. In the more recent year, we worked with the ACOs to take what had been quality forums that they had formed and integrated health services teams which we had formed on the ground and merged them together. We laid on top of that the formation of a leadership team at the local level, which included a recommended set of leaders up to 12 or 13 across the community. So it included the hospital, representation from the 3 different types of primary care and the ACOs, mental health, the Area Agency on Aging, home health, pediatrics, housing-based organizations, plus other local leaders and CEOs. These leadership teams were formed to help identify key priorities and to identify stakeholders and members of their staff to work on quality initiatives across the community. Their goal was to focus on improving the core ACO measures and population health measures through the quality projects that they formed. Each of the leadership teams underneath them for the local community collaboratives, underneath the governance of the CEOs in their area, formed work groups, and each of those work groups specifically worked, again, as I mentioned, on quality projects. Some examples of quality projects that formed included the enhanced care coordination across organizations, reducing emergency room usage through cross-organization collaboration, decreasing hospital admissions, increasing hospice uptake, and addressing addictions. So the current state of play in Vermont is that we started with the foundation of our patient-centered medical homes, which included federally qualified health centers. We very quickly built onto them community health teams, which were shared across the practices, a statewide infrastructure for learning health system activities. We promoted local innovation and local leadership at the community collaborative level. That's actually where the goals and the priorities are set. We enhanced that with statewide self-management programs, and we've been continuously investing in and maturing our health information and comparative reporting systems. At this point, I want to also mention that in the last year, all three of our ACOs have come together and realized that merging to become one Vermont Care organization instead of three independent ACOs would help to enhance the investments in the state, which include creating things like a common analytics system, a common care coordination system, and a common finance system across all three ACOs. It's anticipated that by the mid-2017 and early 2018, we will have one ACO or one merger of the three ACOs into one organization in our state. That also hinges on a Medicare waiver, which will continue some of the investments that were made through the demonstration project that the Blueprint participated in. I'm not going to go into too much detail, but I do want to point out the outcomes that we've seen that have happened in Vermont based on the efforts that are underway. First and foremost, I'm going to point you, if you want more information about the outcomes, to the Population Health Management article that was published in 2015. In that, we were able to demonstrate that for practices who are participating in the Blueprint, there were significant differences in the overall per capita costs in healthcare. Those costs were the difference in those costs were primarily driven by a reduction in overall inpatient expenditures. And we also saw a reduction in pharmacy costs, among many other things. One of the interesting things to identify, and this is why it's important for there to be a NIT for the integrated health system, is that while we saw a reduction in hospitalization and we saw a reduction in pharmacy costs and other types of healthcare costs, what we also saw was an increased use among our Medicaid, where we were able to measure it, of social services such as transportation, supportive housing, and other things that are found in our special Medicaid services. This further reinforces our work to help to connect our patient-centered medical homes to our community-based services in order to achieve the types of outcomes that we received. At this point, I'm going to turn it over to Julianne Krowitz from the University of Vermont Child Health Improvement Program, who is one of the first people in our state to work with primary care practices, including FQHCs, on their NCQA recognition process. At this point, Julie, take it from here.
Great. Thanks, Jenny. So like Jenny said, I work at the Vermont Child Health Improvement Program and oversee 4 of the quality improvement facilitators that help primary care practices in Vermont go through this process. Just to let you know, VCHIP is a population-based maternal and child health services research and quality improvement program here at the University of Vermont. Next slide, please. So there are 6 standards
in the 2014 recognition program. And then within each of these standards, there are a series of elements. Within elements, there are a series of factors. Some of these elements and factors must be passed in order to meet minimum criteria for recognition. Others are not required. They just kind of give you points towards your score. Next slide. I won't go into too much detail around the standards themselves. Rachel and Jenny both pointed out that there are 6 standards. But just to kind of give you a flavor for what that looks like, if we think about the first standard, patient-centered access, there are 3 elements within that standard. The first is appointment access. The second is 24/7 access to clinical advice. And the third is electronic access. The first element, the one that has to do with appointment access, is a must-pass element. So you're going to have to show that you can get patients in for appointments at times that are patient-centered, times that they want, or need to be seen in order to pass the standards. Within each of the other standards, there are must-pass elements and, again, critical factors that you're going to need to focus on. Another thing that's important to recognize throughout the standards is that there's interconnection across elements and standards. So while the third standard has to do with population health management, you're going to see potentially some of the work that you're doing there pop up again in the 6th standard, which has to do with performance measuring and quality improvement. So they want to see that you're reaching out to patients, identifying patients that need to be seen, and then sort of setting goals around that and trying to make improvements as an organization. Next slide. So they thought that it would be useful if I sort of explained in a little bit more detail the process that a practice takes to actually go through recognition. So I'll just sort of describe the general process and then give you an example of an FQHC here in Vermont that's been going through the process. So as Rachel mentioned, the practice is going to submit a web-based survey along with a series of supporting documentation and results from a chart review in most cases to NCQA. Practices who use certain electronic health record systems may be able to attest to certain elements. So in other words, if their EHR or EMR has worked with NCQA to demonstrate that they can meet certain standards, the practice basically just has to tell NCQA that they're using the system in the way that it was meant to be used in order to get the points. They don't actually have to show the examples. NCQA is going to recognize practices that meet minimum criteria, and they're also going to provide a score and recognition level. So they can be recognized at the first level, the second level, or the third level, with the third being the highest. Individual practice sites are recognized. So when you go to NCQA's webpage, you'll see individual practice site names. But many organizations take advantage of what they call a multi-site option and provide organization-level information for some elements. So if you're part of a large hospital-owned system or part of a large FQHC that has a electronic health record throughout your system, who has general policies and protocols that you all follow, you just have to show examples and reports that come at that organizational level, not answer every question for every site. So now to sort of turn to an example, I think it's helpful to think about preparing for NCQA as really being a process. As Rachel mentioned earlier, successful practices are going to begin preparing for NCQA well in advance of submission. NCQA noted, as she said there, 3 to 12 months. But what a practice is going to do is really give themselves time to identify their current systems and processes, identify the changes that they either need to make or want to make, and actually go ahead and make those changes and then study the impact of those changes. So we found that this process typically takes more than a year. NCQA requires that all protocols and processes have been in place for at least 3 months. So this is to make sure that you're not creating a policy just to meet the requirements, but it's something that you actually can follow. So in many cases, practices are thinking about it in a year in advance. What do we want our protocol to be around getting patients in for same-day access, or how do we want to answer emails. And so they want to set that policy or process. They want to try it out, see if it works. Are they actually able to get patients in the way they're saying they'd like to be? Can they financially hold this many slots open? To try those things out, to give themselves time to do it, so when they submit to NCQA, they know that it's a policy that they can actually follow. So I thought I would just give you an example of an organization who's preparing for recognition. It's an FQHC that involves 6 primary care sites. It also includes a critical access hospital, clinics for women's health, eye and dental health, as well as a walk-in clinic. So for our purposes around NCQA, we're focusing on those 6 primary care practice sites, but recognize that they're part of a larger system. These practices were first recognized by NCQA in 2011 under the 2011 standards. Actually, I think under their 2008 standards. They are at level 3 and currently working to renew recognition in 2017. This group of practices will actually be using the multi-site option and are eligible to use some of the more streamlined options here. This group has 2 regular meeting groups that focus on PCMH activities. So these will give you a sense for the type of work they're doing and who's involved. The first is what they call their collaborative meeting group, and it meets in person at least once monthly. It includes clinical and non-clinical staff from each of the practices, as well as from others across the FQHC. These meetings are really focused on how to improve collaboration across sites. The group is facilitated by an outside QI coach, and this person helps them identify opportunities for improvement and to really work on making them. So this group will actually think about doing small tests of change, so doing things like PDSAs, and then rolling things out as they learn from those. So the meeting provides an opportunity to identify, we're not getting the information we think we should be getting from specialists, or during periods of care transitions, things are falling short. How can we make those change? Let's try something new and then come back and talk about it and see whether it's something we want to implement or do a larger test of. And then there's a second meeting, and that is of practice managers from each of the practices. And they actually meet about 2 to 3 hours every week to go over the NCQA standards, identify what they need to do to meet the standards, and really work on developing documentation to submit to NCQA. They find it helpful to meet physically in person away from the office to get things done. It's just sort of an opportunity for the practice managers to work together and kind of not get pulled in many directions, as practice managers often do. They focus on the specific site elements when they get together. The group is led by a person at their organization who's working on sort of the corporate level elements, so those elements that cross the whole organization or all 6 primary care practices. And so she has that general overview and kind of helps lead them through the process of focusing on those elements that they need to focus on. In addition to having this person, they have an NCQA expert, so one of our QI facilitators, the person from my team, who's on call to really answer questions that they have as needed. So she is physically located a couple hours away from them, but she said, during this afternoon every week, I'll be around to answer questions. Give me a call and we can talk through things. We can join a web-based meeting and look through examples and sort of provide assistance in any way they need. And so when we were thinking about how long are they meeting right before NCQA submission, the answer was really no. In total, they'll be holding these meetings for about 18 months prior to submission. I'm sure they miss some weeks, but the idea is that they're sort of continuously thinking about what they do in their practices and how it relates to NCQA and how they can really show that they are a patient-centered medical home. Now, NCQA wants examples and reports to be current, so they want things to be from within that year of submission. So the group is really making sure that they can run a specific report or that they can take the right screenshots, but they're going to probably wait a while before they really start pulling their documentation together. And they'll also wait to conduct their chart review until they get closer to that submission time in 2017. Really, as they work through the standards, they look at other reporting that they're required to do, so things like meaningful use, the UDS reports that they develop, and think about how they can use that information for NCQA so they're not constantly reinventing the wheel. Okay, we can go to the next slide. So practices must renew recognition every 3 years, and level 2 and 3 practices may be eligible for a streamlined or reduced documentation renewal option, so what I was describing before. Next slide. And so lastly, I just wanted to point out, as Rachel did, that NCQA's program will be going through some transitions in 2017. So they will not only be transforming from what they call their 2014 to 2017 standards, but they'll also be transitioning from a 3-year recognition to more of an annual renewal process that will require more limited documentation, but more frequent documentation or talking to NCQA. And then they're also, as part of that, going to transition from a single submission to really working with NCQA staff to prepare and share documents as they're prepared and ready to do so. That's what I've got. Thank you.
Well, thank you so much, Rachel, Jenny, and Julianne. We really appreciate those presentations, and they're very informative. At this point, I'm going to open it up for any questions that anyone has. If you want to type anything into the chat box, please feel free. I don't think we have any questions at this point. But also, if you have a question, feel free to unmute your line and ask the question now. So I'll stop there and see if anyone has any questions at this point. So I have no questions at this point. Julianne, Jenny, and Rachel, Julianne, you mentioned this, but one thing we were just wondering, how is the transition, how are people responding to the transition to an annual renewal cycle as opposed to the 3-year?
I think they're all trying to figure it out. We actually had a number of practices here in Vermont help NCQA pilot this new program. They piloted both what they call a sustaining model for those practices that have already been recognized, sort of what the renewal process will look like, as well as help them pilot the program for new practices coming on board. And I think that the reactions were positive in that it seems a little bit less like busy work for practices that have been doing this over time, so they're not constantly having to show, or prepare every 3 years all the same documentation. It's really building on what they've done in the past. I think the reality is once we get into it, it's going to seem like that year comes around very quickly. So I think it does help practices sort of think about this as being a constant process as opposed to a discrete point in time that you're preparing documentation for.
Thank you. Any other questions from the audience? One other question from the ASTO staff. How was Vermont able to align the patient-centered medical homework they've been doing with their SIM plan? Can any of you respond to that? Which, if not, don't worry. But
yeah, actually, I can. So within our SIM plan, we were able to take a look at the infrastructure that we already had on the ground. and we used the SIM funding to advance that. A couple of examples. When it came to health information technology, we used some of the money to invest in the licensing fees for a statewide clinical registry to help us produce the data and analytics, and to also enhance some of the work that's being done on the Health Information Exchange and the connection of that to our emerging ACOs. In addition to that, we invested in learning health systems activities, which included a learning collaborative for integrating care across organizations for at-risk individuals, and a learning health system activities to assist communities in beginning to think not just of individual patient care, but also on becoming an accountable health community, so starting to look at the upstream prevention ends of things. Those are a few examples. The way that we came to that is we convened several different work groups. One of the work groups helped to align the measures across the 3 different ACO categories, so across Medicaid, Medicare, and the commercial, so that there was one common set of measures that were based on the Medicare measures but expanded for additional populations. So each of those work groups helped to identify how we could move things forward further in Vermont. First with the measurement, another with the health information technology, a third overall on population health. Then there was a committee that looked at how to provide care models and care management. That's the one who invested in the learning community. And so you begin to see them looking across sectors and how they can advance the foundation that was already here through the blueprint before we received the SIM grant.
Thank you, Jenny. So any other questions from the group? Okay, well with that, we will end just a little bit early. If you have any follow-up questions, please use the contact information on the screen and we'll ensure that our speakers receive your questions. Thank you all again for joining us today. Thank you so much to our speakers for joining us and giving these presentations. And as we mentioned earlier, you'll be immediately directed to an evaluation at the conclusion of today's webinar, and we'd really appreciate if you take a few minutes to complete that survey. And we will also be posting the recording and the slides on ASTO's website in the next couple of weeks, so you should see that soon. And with that, thank you again to our speakers, and thank you all, and enjoy the rest of your day.